Good afternoon. My name is Janie Gordon, and I'm the Program Administrator for the Mid-Atlantic Public Health Training Center. On behalf of the Training Center and the Maryland Department of Health and Mental Hygiene, I want to welcome everyone to today's presentation, our July Public Health Practice Grand Rounds on back-to-school immunizations, the impact of public health laws. I have a few announcements before we get started. For people who are watching online, please check out our archive Grand Rounds and other online trainings. Our next Grand Rounds on August 21st will address obesity prevention strategies, what policies work. Be sure to mark your calendars. For those watching online, you can email a question for today's presenters by simply clicking on the link, or you can send your email directly to maphtc@jhsph.edu. With that, we're ready for our presentation on back-to-school immunizations, the impact of public health laws. I'd like to introduce today's speakers. First, we have Daniel Salmon. Dr. Salmon is an associate professor and deputy director of the Institute for Vaccine Safety at the Johns Hopkins Bloomberg School of Public Health. His primary research and practice interests are in optimizing the prevention of childhood infectious disease through the use of vaccines. He is focused on post-licensure vaccine safety and the factors associated with parental decisions to vaccinate or not vaccinate their children. He's conducted studies examining the rates of vaccine refusal, the reasons why parents refuse vaccines, the impact of healthcare providers and local and state policies on vaccine refusal, and the individual and community risks of unvaccinated children. Other interests in research include the financing and delivery of vaccines, vaccine risk communication, and issues surrounding mandatory immunizations. Claire Hannan is Executive Director of the Association of Immunization Managers, representing state, territorial, and urban area immunization programs. Previously, she was Immunization Policy Director at the Association of State and Territorial Health Officers and worked for Senator Barbara Mikulski. She holds a bachelor's in political science from Wagner College in Staten Island, New York, and an MPH from Johns Hopkins in Baltimore. She is published in Pediatrics and the Journal of the American Medical Association. So I will pass the mic over to Dr. Salmon.
Good afternoon. I'm going to start by giving a fairly broad overview of the issue of school immunization requirements and exemptions from those requirements, and share some of the science and health services research in this area. And then Claire will get into some more specific issues that have come up in various states. So compulsory vaccination in the U.S. has a very long and rich history. The first law requiring vaccination in the U.S. was in Massachusetts in 1809, and it required the general population to get smallpox vaccine. There was a case where Mr. Hannan Jacobson didn't want to vaccinate himself. He felt that he was at increased risk for an adverse event and refused to be vaccinated. The state fined him $5 in accordance with the law, which may not seem much, but in 1809, I think you got more than you did today. And the state then prosecuted him for not vaccinating and levied the fine on him. He sued, and it made it up to the U.S. Supreme Court, who ultimately upheld the right of states to compel vaccination as a use of their police powers. And ultimately, this case, Jacobson versus Massachusetts, has been the foundation for public health law in this country. In 1922, the Supreme Court took up the issue of requiring vaccination as a prerequisite for school entry. And this is a time period in the U.S. where school was becoming mandatory, and vaccination was used in some jurisdictions as a contingency for entering school. And in fact, the Supreme Court upheld again the right of states to require vaccination in order to attend school. I'm skipping through about 150 years here, getting to more modern immunization requirements. And in 1963, 20 states had such requirements. This grew to 29 in 1970. And generally speaking, in this century that I've skipped over, we saw that when there were outbreaks of disease, particularly smallpox, states would be more likely to enact and enforce school laws. And then, as was often the case with diseases, there would be a cyclical nature, or because of vaccination, there'd be less disease. And then during those time periods, there'd be more opposition to vaccines, and the number of laws would be reduced. In the 1970s, the push was really on measles. And here's some data from that time where you see the incidence of measles per 100,000 persons under 18 in 1973 and 1974 in states that had laws and states that didn't have laws. And what you see is that states that had laws had a much lower incidence of measles compared to states that didn't have laws. However, as is often the case with laws and with public health laws, the existence of the law is one issue, but it's also important to consider implementation of the law. And here's some data coming out a year later from CDC looking at states that strictly enforce school laws versus the remainder of the nation, comparing the incidence of measles for children under 18 or young adults, persons under 18. And what you see again is that states that strictly enforced the laws had much lower rates of measles compared to the rest of the nation. So the emphasis in the 1970s was both on enacting laws as well as enforcing the laws. So initially, as I've pointed out, the intent of the laws were to prevent outbreaks of disease. And this is a really important point. For example, with measles, disease was widespread. School-aged children were disproportionately affected, and often school was a site of disease transmission. So the enactment and enforcement of these laws was very clearly to control disease. But retrospectively examining the laws show they provide other benefits as well. They provide a safety net ensuring that all, or nearly all, and we'll talk about that in a few minutes, nearly all children get vaccinated by school entry. And in many ways, the school laws get rid of many of the other factors that might cause differences in vaccine coverage, like education or income. The laws apply equally to all populations. They demonstrate a public commitment to immunization, and a public health commitment and a school commitment to immunization. So this is, as I mentioned earlier, often when disease is common, people are focused on the risks of disease and immunization and school laws. And then when disease starts to fade, people focus on different issues. But school laws continue and can make sure that immunization rates stay more stable. And they can also be useful in introducing new vaccines. And here's some data from 2000 when varicella vaccine was being introduced, and we see vaccine coverage on the y-axis and the different states in the x-axis, and the national coverage rate at that point was 67%. And states in red are states that had child care requirements. And you see that every state that had a requirement had at least the average rate of coverage, and 5 out of 6 states with the highest rates of coverage had child care requirements. So this suggests that the requirements for child care helped ensure that children were vaccinated for the introduction of a new vaccine. So how did the laws work? Well, firstly, these are all state laws. There's no federal law requiring vaccination for school entrance. As I mentioned, this is the authority of the state through their police powers. And because they're state laws, there's a lot of different ways of doing things, and there's a lot of variability in terms of what antigens are required. Some require, for example, it'll say specifically measles and mumps and rubella vaccine. Others might say just measles. In that case, it's probably not a big difference because the vaccine is usually given together. But some states require varicella or Hep B and others don't. There's a lot of variability in how you add new antigens or make changes to the law, and Claire is going to talk about this more. What populations are applicable to the law also varies. All states have laws for school entry. Some have child care, some have middle school, some have college, and there's also variability in who provides the documentation. So in 46 states, the physician is required to fill out an immunization card that documents the child is fully vaccinated. The remaining 4 states allow a parent to fill out that card. And in fact, if you go online, you can find a website that will tell you how to fill out that card if you're a parent, with dates that would work, clearly not showing that the child is actually vaccinated. All states also offer medical exemptions to school immunization requirements. 48 states offer non-medical exemptions. So the 2 states that only offer medical exemptions are West Virginia and Mississippi. 29 states offer what's called religious exemptions, and an additional 20 states offer philosophical, religious, and medical exemptions. So often there's a distinction that's made, albeit perhaps not entirely clear, between religious versus philosophical or personal belief exemptions. And I'll talk about this more in a few minutes. So studies we've done have found that there's tremendous variability in how states implement their exemption processes. So for example, in Maryland, if I want to enroll my child in school, the school would give me an immunization card. I would bring that card to my pediatrician, who would pull my child's medical record and complete the card. My pediatrician charges $5 for doing so. I would then take that card back to the school with the provider's signature, and I could enroll my child. Alternatively, there's a sentence on the card that says, immunizations are contrary to my religious beliefs. So I sign that statement, and my child has a religious exemption. The state never looks at what religion or tries to validate that that's a true religious exemption. And in fact, it's easier to get a religious exemption than to document your child is vaccinated, because I simply sign my name, I never leave the school building, and I'm considered, my child has an exemption. But that's considered a religious exemption because it says contrary to my religious beliefs. Until very recently, and I think again Claire will talk about these changes, California had essentially the same procedures, but it said due to my personal beliefs. So that would be a personal belief exemption. But again, you simply sign it, you're exempt, and that's it. So there's a distinction in that example between religious versus philosophical, but in the process is truly the same. And this study I mentioned that was done by Jennifer Rhoda found that states that had easier processes for granting exemptions had higher rates of exemptions. And here we see some data from that study, and we see on the y-axis states that had easy, medium, or hard processes for granting exemptions. So this looks at things like, does the state require annual renewal? Is there a form like in Maryland and Washington where you simply sign your name, or do you have to write a personal statement explaining your beliefs? Do you have to get any sort of health education? Does it require notarization? So this was the sort of thing that was looked at in administrative difficulty. And then we see on the x-axis the rates of exemptions, low, medium, and high. And you will notice that there were no states at this time that had hard exemptions and high rates of exemptions. And there was a clear association between the two. I didn't provide the data, but there was a paper that came out this month in Health Affairs that replicated this study more than a decade later and found the same thing. In addition, the study found that often there was little contact between parents and health personnel when parents were requesting an exemption. So a parent would come into the school and provide an exemption request, and it was handled as a administrative procedure. Thank you very much for the form. Your child is now enrolled. But there really wasn't any discussion of the risks and benefits of vaccination. And clearly this is a missed opportunity, because you have parents coming in saying, I don't plan to vaccinate my child. And instead of trying to understand and address their concerns, it simply put a form in a pile. It also found, the study, that the majority of states never deny an exemption request. So states like Maryland that might call their exemptions religious, by de facto are really offering an exemption to anybody who wants one, because they're not denying exemptions. And lastly, that states rely on schools to implement and enforce these requirements. So let me take a step back and say, well, why is this an issue? Why are we worried about children that aren't getting certain vaccines? This is an issue of parents making choices for their children, which of course it is. At the same time, if I don't vaccinate my child, then my child may be at risk of disease transmission, of contracting the disease and disease transmission. So studies we've done have found that children that aren't vaccinated are at increased risk of measles, pertussis, HIV, varicella, and pneumococcal disease. So this makes sense. If the vaccine works, or works pretty well, and the disease is circulating, if my child isn't vaccinated, my child may be more likely to get disease. There's also the potential for transmission of disease. So in this slide, we see the increased risks of measles and pertussis for exempt versus vaccinated children. And these studies found that children that had exemptions were 22 to 35 times more likely to get measles and about 6 times more likely to get pertussis. But getting at the community risk, a study done in Colorado found that counties that had outbreaks of pertussis had a much higher rate of exemptions than counties that didn't have outbreaks of pertussis. And this starts to get at the community risk. So if my child is at increased risk of disease, my child may pose risk to your child or to other children. And why is that? Well, maybe your child is too young to be vaccinated. Maybe your child can't be vaccinated for medical reasons, and there are children that simply can't be vaccinated because they have contraindications to the vaccine. Or maybe your child was vaccinated and didn't have a sufficient immunological response to the vaccine because no vaccine is 100% effective. So looking at exemptions over time, here's some data that looks at states that only offered religious exemptions versus states that had personal belief exemptions between 1991 and 2007. And what we see in the states that only offer religious exemptions was that during this time period, the rates really stayed pretty stable over time. Whereas states that offered personal belief exemptions, there was a clear increase in exemption rates over time. Here we're looking at exemption rates by states among states that had easy, medium, or more difficult exemptions, and we see that the states that had easy exemptions had a fairly large increase over this time, where states with more difficult procedures really didn't see much increase. More recent data shows an increase in states overall, but the increase was occurring, this is from 2006 to 2011, both among states that offered religious and personal belief exemptions. Likewise, the processes for exemptions seem to suggest that states that had difficult procedures didn't really see an increase over time, whereas states with easy or medium difficulty in exemption policies did see an increase over time. Looking at both the impact of the type of exemption, religious versus philosophical, and exemption ease on pertussis, finds that both of these policies were associated with the rates of pertussis. So if you lived in a state that had a religious exemption or states that had an easy exemption, you had about a 50% higher rate of measles compared to other states, adjusting for a whole sort of confounders. So this is suggestive, at least, that there's a direct relationship between how states implement and enforce exemptions, the rates of exemptions, and the rates of disease in those states. We also found that there was considerable variability within states in how they implemented and enforced the laws. So you might say, well, Massachusetts only offers a religious exemption. But when we surveyed schools in Massachusetts and we asked them what type of exemption they offered, about a quarter of schools said they offered a philosophical exemption, even though the state law said they didn't. And there was tremendous variability in things like annual renewal and the processes for granting exemptions and whether or not the schools denied exemption requests. And as we found on the state level, we found that schools that had easier processes for granting exemptions had higher rates of exemptions. And we also found, again, that many schools do not discuss the risks and benefits of vaccination with parents who are considering an exemption. So again, this is a missed opportunity for risk communication. We looked at the training of the person in the school who works with parents on immunization issues and what their attitudes and beliefs were and whether or not that was related to the exemption rate. And as you might suspect, it was. Some schools had nurses who worked with parents, so a parent coming in to get an exemption would be directed to the nurse. Other schools had administrative assistants or principals. We found a school where a bus driver was the person that talked to parents about vaccine issues and accepted the forms. I suspect the bus driver didn't go through any training in this regard, and having a nurse made a huge difference. If your school had a nurse to work with parents on immunization issues, the exemption rate in that school was about 50% lower. We also found that that person's perceived susceptibility and severity of disease and safety and efficacy of vaccination, who they thought benefited from vaccination, whether or not they recognized both the individual and community benefit of vaccination, whether or not they had misconceptions about vaccines. Confidence in local and state health departments were all associated with the rates of exemptions in the school. So this is suggestive that the person working with parents may really have an influence on those decisions that they make. Looking again at the community risk of exemptions, we did a study in Michigan where we looked at the clustering of exemptions. So one needs to be careful here when you look at exemption rates. It's kind of like politics. It's all on a local level. So a state may have a 5% exemption rate, and one would think, well, that's 5%, that's not that high. But in fact, those exemptions may be clustered in one geographical region, and that increases the risk of disease. So from the perspective of a parent that wants to protect my child, it really doesn't matter what the national rate of vaccine refusal or exemptions are, or the state rate of exemptions. The risk for my child is the likelihood of my child coming into contact with another child who might transmit disease. And if I live in a community with high exemption rates, that there's an increase there. So here we see the state of Michigan, and in red we see the clusters of pertussis, and in yellow we see the clusters of exemptions. And we found that in Michigan, if you lived in an exemption cluster, you were 3 times as likely to also live in a pertussis cluster. So this really makes 2 points. One is this clustering phenomena, and I'll show you more data on this, but also that there's a clear community risk that's associated in these high exemption areas. Here we're looking at Washington State and exemption rates by county, and I'm going to show you a few slides over time. And I apologize that the colors changed. That was out of my control. These slides are from Washington, but as you get on with these, look at the darker color red, which here is over 5% exemptions. And now we see counties with much higher rates of exemptions in 2006 and 2007, and then 2007 and 2008. And let me stop here for a minute, and I'll show you more recent data. But in this year, in this school year, 6% of children had an exemption to 1 or more vaccines. So that's high compared to other states, but it's not that high. Right? It's not an outrageous number. But if you look at some counties, you have exemption rates as high as 20 or 25%. So if you live in those counties, it may make you feel better emotionally that the rate's low in the state, but your child has a 1 in 4 chance of coming into contact with another child, or 1 out of 4 children your child comes into contact with isn't vaccinated for one of the required vaccines. And we see a tremendous amount of clustering here. Now, more recently, the rates have gone down a little bit from 6.3% to 4.5%. And this is probably a result of changes in the law. It could also be a result of a tremendous amount of pertussis in Washington State because there's been a huge resurgence. But nevertheless, the rates have dropped a little bit, and I think Claire will talk more about that. But even with this lower rate of exemptions, you still have places with very high exemption rates, 10, 15%. So why do parents claim exemptions? Why are parents making a decision to not vaccinate their children? And as public health people, I think we see the tremendous value of vaccines. And this slide really depicts this. If you want to look at the impact of vaccines, here you look at the rates in the pre-vaccine area of the diseases that we typically, the more traditional vaccine preventable diseases, and the rates in 2011. And we see a tremendous reduction in disease with a possible exception of pertussis, but smallpox has been eradicated. What a tremendous, tremendous achievement of public health. There's no more disease, and there's no more need to vaccinate. And the number of lives saved and the dollars saved is tremendous. Polio is near eradication. We haven't seen a case of polio in this country in decades, and the incidence of most other vaccine preventable diseases has been reduced by 98 or 99%, which is truly remarkable. I mean, few medical or public health interventions can show this sort of impact, and often a very short period of time. But the story gets a little bit more complicated, and now I've added another row here, which is reported vaccine adverse events. And let me just be clear, these are being reported to a passive surveillance system, so there's underreporting and there's overreporting, and it's not a perfect number. But the point I want to make is that before you have vaccines, you have nobody who thinks they've been injured by vaccines. But once you have vaccines, people will believe that there are injuries. And often the rates of reported adverse events are at or even higher than the rates of disease. And this next figure, which is a bit complicated, in many ways explains this. In the y-axis, we have incidence or rate, and on the x-axis, we have maturity or time. And when we have no vaccine, we have very high rates of disease. And then we introduce a vaccine, which is reasonably effective and reasonably safe. And as vaccine coverage goes up, disease comes down, right? This is why we vaccinate. And then as vaccine coverage goes up, so do reports of adverse events. And we hit a point somewhere around here where the rates of adverse events are actually higher than the rates of disease. And that's the situation we face now for many vaccine-preventable diseases. And in this situation, parental perceptions and fear can easily shift from fear of disease to fear of vaccines. So if you look at polio, before we had a vaccine, people were terrified of polio. And people of my grandparents' generation didn't go to swimming pools and didn't go to movie theaters because they were afraid of polio. And the inventors of polio vaccines, Salk and Sabin, were national heroes. They were celebrities. Could you imagine scientists being celebrities? And the clinical trials for the polio vaccines were the largest clinical trials ever done. And people lined up their children in hopes of getting a vaccine that might work. But who today has seen polio, unless you've been in other parts of the country or older than I am? You haven't seen it, and few clinicians have treated polio. So people aren't afraid of polio like they used to be. It's a disease that happens in remote parts of the world and it exists in textbooks. On the other hand, let's take autism as an example. People are terrified of autism. I think most people know someone or in their own family have an autistic child, and it's a very, very difficult disease, and those families have struggled tremendously. So when someone hears prevent polio, but maybe there's a risk of autism, it's the autism they're worried about. And the result in this situation where the focus of people are on vaccine safety issues instead of the diseases that are being prevented is often a loss of confidence in the vaccine. And we see this with the wholesale pertussis vaccine in the 1970s and 80s in many countries, Japan, Sweden, the United Kingdom. We see this in much of Europe now with the MMR vaccine, where there were drops in coverage because people were concerned about autism in this case. Despite a lack of scientific support for that concern, there were drops in coverage, and there were quickly resurgence of disease. And then moving to this point, now diseases come back. So fear results from seeing the disease. There's a resumption of confidence, coverage goes up, and the disease goes back down. So this is the evolution of immunization programs, and we see this in many, many countries, and it's only furthered by disease eradication. Presumably, if you eradicate a disease like smallpox, you stop vaccinating. However, that may not be the case. If we were to eradicate measles, for example, we would probably have to keep vaccinating indefinitely for fear of it being reintroduced, perhaps by a bioterrorism event. So picture a world where there hasn't been a case of measles for decades, yet we need to keep vaccinating the entire population. So this is, albeit a fairly complicated slide, I think explains much of the situation we face now and relates to why some parents claim exemptions and don't vaccinate. We know through surveys that parents that have exemption perceive their children to be less susceptible to disease, the diseases to be less severe, they feel that the vaccines are less safe and effective, and they have less trust in healthcare providers and the government compared to parents that fully vaccinate their children. So let me take a step in a slightly different direction and talk about some of the legal issues. So from a legal perspective, states are not required to offer non-medical exemptions. I think it's fairly widely accepted that they don't have to do so. As the Jacobson case showed, they can require vaccines of everyone, Medical exemptions is probably a different story, but it's not an issue because all states do. But if states do offer non-medical exemptions, they have the authority to create administrative requirements, as I've been discussing, things like annual renewal and health education, but they may not be able to focus on the nature of religion. And I'll give as an example the Arkansas exemption up until 2002. And the way the exemption worked in Arkansas, which was a religious exemption, was that the immunization had to conflict with the religious tenets and practices of a recognized church or religious denomination of which the parent is a member. And to show that your church is recognized, an applicant had to provide a copy of the religious doctrine and details of the church, like their location and number of members. And at this time, there were two parents that requested a hepatitis B exemption. And they wrote a statement that talked about the body being a temple. So perhaps there was a suggestion of a religious connotation, but they didn't submit the doctrine or location of the church, and the state consequently rejected the exemption request. And the parents filed a lawsuit, and it made it up to a U.S. District Court. And the U.S. District Court found that the religious exemption violated the Establishment and Free Exercise clauses of the First Amendment and the Equal Protection Clause of the 14th Amendment. In other words, when the state tried to recognize certain religions but not others, that was a unnecessary entanglement of state and religion, and the court eliminated the religious exemption and severed that from the school immunization requirement. So basically, the court said to these parents, we agree that this exemption is unconstitutional, and therefore it doesn't exist anymore. Now, that may not help you because you still have to vaccinate your child, but if you don't like the way it is, go talk to your legislature, because it's their job to write a law that's constitutional, not mine. And the result was a lot of momentum for Arkansas to have a very broadly written philosophical exemption, like in California. And I don't mean to pick on California, there's lots of states like that. At the time, there was momentum for this very broadly written personal belief exemption, and a group of us wrote a letter to Faye Boozman, who was the Commissioner of Health, and said, look, if you're going to have an exemption that's philosophical, use some of these administrative procedures that in other states have found to be associated with lower rates of exemptions. And certainly it shouldn't be easier for a parent to have an exemption than to vaccinate their child. And there really needs to be some risk communication. And at their request, we worked with the Arkansas Medical Society to develop a model law. And what we did was we first put the burden on the parent. And we said, okay, the parent had to furnish a signed personal statement explaining why they want an exemption. In other words, don't just download something off the internet. Don't give them a form. Put the burden on them. And they also had to show that they had educational counseling about the risks and benefits of vaccination. And then based on that, the state would then weigh the sincerity of that parent's beliefs based on what they said in their letter with the risks of exemptions, looking at vaccination rates and vulnerability to disease and prevalence of disease. And based on this balance, the state could either accept or reject an exemption request. And if they rejected it, there would be an appeals process. And if they granted it, there would be an annual renewal. And the annual renewal served a few purposes. For one, it has been associated with lower exemption rates, but it also makes sense because a decision that I make for vaccination for my child today may be different if I revisit it down the road. Maybe the science has changed, maybe the risk of disease has changed, maybe my own values have changed over time. So the annual renewal is both associated with lower rates of disease, but also makes some sense, at least intuitively. Arkansas didn't want the authority to deny an exemption request. It was an election year with a Republican governor who had ran on a platform of individual autonomy, but they did include an assessment to the law. And we looked at these data over time. Here we see the exemption rates in the 2 years before the law changed versus the 2 years where the law did change. And we see the rates of medical exemptions decreased. So probably some parents were getting medical exemptions when they weren't really medical. The rates of religious exemptions decreased, but there were these new philosophical exemptions. So there was already a trend of exemption rates going up. And ultimately, in that year, about 100 kids roughly got exemptions in the year before. If you look at the increase here in this slide, we look at the absolute numbers versus the percent increase from the previous year versus the increase from an absolute standpoint. And I can tell you that the authors of this paper and the peer reviewers of this paper argued over how to interpret this. Some people said, oh my God, there was a 17% or 50% increase in the rate of exemptions. Look at what's happened. This is a huge risk. And I showed you data earlier on why more exemptions means more risk. And others, myself included, said, the absolute numbers are really small. I mean, you see 113 extra children in the entire state. And while as a public health person, I want to see all children whom are eligible for vaccination to be vaccinated, from a public health standpoint, you're talking about a rate of about 0.2%. And it's, I think, really hard to argue epidemiologically that this is a significant risk factor. Texas was in a similar situation after Arkansas. Their law was also very strict on religious grounds, like Arkansas. They changed their law because they were concerned about a court doing the same thing to their law, and they again found very small rates of exemptions over time. So I'm moving now to a more controversial issue, which was HPV vaccine requirements. And Texas actually passed the first law for all sixth graders in 2008, and it was passed by a governor's order with no public comment. And people are probably familiar with this, particularly as this governor was a presidential candidate, and this came up to haunt his candidacy. And I think in many ways this slide says it all and perhaps too much. Here we see the governor receiving a nice stack of money from an overweight gentleman with the name Merck in his briefcase. And in the background, we see what used to be the best little whorehouse in Texas, which is now the best little vaccine house in Texas, with an offer to get your sex vaccine here. And the governor says, we finally found a legal way to exploit the bodies of teenage girls. And the Merck representative is very happy to do business with him. And this is clearly what we don't want to have happen in public health or the vaccine context. And we don't want people to perceive that school laws are a desire to further the sales of pharmaceutical products. So there's a balance here between the parental autonomy to make decisions, between the public health benefit of vaccines. Ultimately, the legislative of Texas repealed this law. So moving forward, as I mentioned, I think what we need to do in public health is try to balance this parental autonomy with public health goals of preventing disease. One question that remains unanswered, and again, I think Canary Claire will talk about, is whether states that have high exemption rates and easy exemptions can reduce their rates through more administrative procedures. So what happened in Arkansas and Texas suggests, granted a sample size of 2, but suggests that a state that used to have a very, very restrictive religious exemption can change that to a philosophical exemption, which essentially allows all parents in the state to make a decision. If they have administrative requirements, the rates did not skyrocket. What's less clear is if states like California, not to pick on California, that have very easy exemption rates, if they were to make them more difficult, would they see drops in exemption rates? And lastly, what to do with new vaccines as they become available. I mean, I think this is an issue that will continue to arise. I showed you some data suggesting that laws can be helpful in introducing new vaccines, but as we have a huge number of vaccines coming through the research pipeline, heading towards licensure and recommendations, and the immunization schedule is becoming more crowded with more vaccines, do we really want to require every vaccine for school entrance? And I think this is an important issue we need to think more about. So I'm going to stop here and turn it over to Claire, who will share some of the state issues. Is that you?
Thank you, Dan. This is a great occasion for me to be back at my alma mater. I'm a proud graduate of Johns Hopkins, so thank you for having me, Janie. As she mentioned, I am executive director of the Association of Immunization Managers, which is a nonprofit membership association, and our members are the managers of the immunization programs, mostly in state health agencies, but also in territories, and there's 6 large cities that get direct funding from CDC, and their managers are our members as well. Dan provided a really in-depth analysis of the data out there around vaccine requirements, which was awesome and very thorough. It's great background to talk from my perspective, from the state perspective, about what we've learned and, sort of where we're going and what the trends are right now. I hope. Okay. So just to look at the lessons learned, to summarize a lot of the data that Dan discussed, school vaccination requirements are an effective tool to assure high immunization coverage rates and prevent vaccine-preventable disease in school children. Lots of studies showing that. State governments have found that they are most successful when they're accompanied by public trust, provider knowledge, and public health support. We saw this in Texas. Exemptions can be a challenge to states and can put children at risk. So how do states get the requirements? Dan touched on this, but it is a state issue, and states are not the same. They are different for different reasons. We all know that in elections. But school immunization requirements are established at the state level either through legislation or regulation. 39 states have a rulemaking process. The rulemaking process allows a state health agency to add new vaccines through an administrative process. The goal with that is taking politics out of it. It doesn't go through the state legislature. However, it's a process that does call for hearings. It calls for public comment. It does allow for public input. There are 11 states that require legislative approval. So in those states, it does have to go through the state legislature. Most states have an immunization advisory committee, and this is a group of experts, stakeholders, partners who evaluate issues, look at data, and make recommendations to the state. But all of this process allows for data review and for public input. Also, just to talk a little bit about, from the state perspective, that laws alone are not enough to assure immunization coverage and to prevent disease. There's a lot that goes on behind the law to implement it and to make sure that it's working. It takes communication, it takes education, partnership with the schools, recording and tracking compliance, and enforcement to make sure that the kids get vaccines. We couldn't just put a law in place. I mean, any parent knows you can't just tell your child, do this because it's the rule. Eventually, you're going to get some feedback that that's not working. So you really have to work hard to educate, to make sure parents are aware, providers are aware, and that's the role of public health. Just to give you an example of this, the state of Maryland, in September of 2006, added a school requirement for hepatitis B and varicella in their middle school age group. To prepare for this, they did extensive outreach to parents and schools. They wrote letters to every principal. They educated physicians. They had a radio ad campaign, and they got extensive media coverage about the change in the requirement. They also contributed $4 million for back-to-school vaccine clinics to make sure that the vaccine was available, that parents had access to it, and they did a statewide education campaign. There were 280,000 students in the affected grades, which was 6 through 9, and approximately 53,000 were in need of hepatitis B, and 126,000 were in need of varicella or documentation of having had chickenpox. So a year and a half after September 2006, when the law was enacted, by January of 2007, there were still 12,000 students in need of vaccine or documentation. So adding a requirement, particularly in the middle school years, is it's a tremendous effort, And it's a huge public health, extension of resources and massive effort. I wanted to share with you our position statement, the AIM position statement on childcare and immunization requirements. We developed this statement. Immunization program managers got together and discussed how should we use state school requirements responsibly. How can we make sure that this is an effective tool? How can we make sure that we maintain public trust? And how can we make sure that moving forward, we add vaccines when we can get the most effectiveness out of the law? And we talked about this really as we went into HPV, and HPV vaccine came out. It was a little controversial, as Dan described, and a lot of people felt that we should just require it in order to get the rates up. The rates were low. They're still very low when you compare them to other adolescent vaccines. And a lot of people thought the answer was to just require them. So we had a lot of discussion. We have a lot of program managers who had 20 or more years experience really helped to cultivate this statement. And we talked about having an implementation period. And that's what I want to focus on. The statement says that school and child care immunization requirements must be used sparingly, approached cautiously, and considered only after an appropriate vaccine implementation period. This implementation period allows time to assure that insurance coverage is in place for vaccines, especially new vaccines, which can be more expensive, that there is sufficient funding in public programs to make the vaccine available as a safety net, that physician and providers are on board, they're buying into the vaccine, they support it, that there's public acceptance of the vaccine, that there's a stable supply of the vaccine, and adequate data to assure vaccine safety. Also that the vaccine has been added to immunization information systems, and so the recording of it is ready to go. And then a time period to allow significant uptake to reduce the compliance burden on the school system. Going back to the state of Maryland, they had higher rates at the time than we currently have in HPV, and they still had this tremendous number of children to vaccinate in a short period of time. So we really have to take that into consideration. The other thing that is part of the requirement position statement we have is that mandates must be evaluated carefully, including epidemiologic, economic, and ethical concerns. If we just mandate something just to increase rates, we're going to get some pushback from the public. Inappropriate application of mandates risks loss of support for immunization programs and reversal of policy and program gains. I talked about the existing state processes, and it's very important to use these processes rather than to develop legislation or to do what Governor Perry did in Texas and just mandate something. These processes are in place really to assure public input, and so we recommend in our statement that these processes be used and not have separate legislation. And also to respect the flexibility of the state and their laws and what they have in place as far as exemptions, and not to alter that with a new vaccine. Dan touched on exemptions, which are probably the hottest issue right now with school requirements and what is happening with exemptions across the country. Exemptions to requirements are allowed in all states for medical reasons. As Dan talked about, there are 48 states that allow exemptions for religious or other reasons. And some of what is written in these state criterias are personal beliefs, personal reasons, conscientiously held beliefs, philosophical or personal exemption, other grounds, or other written objections. And as he mentioned, in some states, you can just check a box. Again, this is just showing you that 5 states do not have religious exemptions. This one is showing the personal belief exemptions. And personal belief exemptions are sort of categorized as personal conviction, conscientious objection. 19 states allow for those exemptions. And I just wanted to give you that backdrop as we talk about exemptions. Dan talked about how if a state has a easier mechanism to get an exemption, they have higher rates of exemptions. He talked about the data showing that exemptions have higher risk of disease, and I'm going to talk a little bit about that. But the number and percentage of kindergarten children with reported exemption rates is shown in this slide for 2011 and 2012, and you can see that it really varies, with Oregon at the top with 5.8%, and of course West Virginia and Mississippi, who don't have personal exemptions, at the bottom. Again, it's not just the rate, it's also the clusters within the state, as Dan talked about. I want to emphasize the impact of these exemptions on disease. I think that that's the most important thing as far as parents are concerned, as far as public health protecting from disease. Exemptors were 35 times more likely to contract measles than were vaccinated persons. Exemptors to school immunization requirements were 22 times more likely to acquire measles and 5.9 times more likely to acquire pertussis than were vaccinated children. Vaccine refusers had a 23-fold higher risk for pertussis when compared with vaccine acceptors. Vaccine refusers had a 9-fold higher risk of varicella illness. So from the state perspective, we have these requirements that we know work. They're a solid tool. We want to maintain and cultivate public trust. We know that if we mandate a vaccine just to get high coverage rates, we may damage public perception. But now we're starting to see more and more data on the impact of exemptions on disease, and it really is posing a threat. The exemptions have increased, and so we're looking at ways to do something about that. There's also an economic impact of exemptions. There's a recent study in Vaccine showing that adding a personal belief exemption in a state will cost that state 50% more annually in hospitalization costs and non-medical costs related to pertussis disease. So the non-medical costs are around missing work, traveling to the doctor, all those expenses involved with cases of disease. There's also a high cost to public health in response to an outbreak. A local health agency response to school-based pertussis outbreak resulted in 1,032 person-hours spent and $2,172 per case of disease. This study is from the MMWR, and it's the Douglas County Health Department in Omaha, Nebraska. They responded to a pertussis outbreak with 26 cases in 2008. So this is an outbreak with 26 cases. The most recent outbreaks and what's happening with pertussis going up involve hundreds of cases. And it's a massive effort for public health to track down who's been exposed and to make sure that they're protected from disease. So what can states do? Looking at all this data, trying to balance using the requirement and trying to look at the exemptions going up and what can we do to protect and use exemptions wisely. There is a movement to strengthen exemption laws to reduce risk. And the goals of these types of strengthening laws are to assure that parents have reliable information to support vaccination decisions. And many of these look at requiring education or a consultation with a healthcare provider. The goal is really to make sure the parents have reliable information, that they're not just going on the internet, or they're not just checking the box to make sure that their child can enter school. Getting the vaccine should be as difficult as getting the exemption. Also, the goal is to assure that requests for exemption from immunization requirements are, as we said, based on conviction and not convenience. So these are states that had legislation pertaining to non-medical exemptions in 2011 and 2012. And you can see that there are more bills to expand exemptions than there were to strengthen exemptions. 8 to expand exemptions and 4 to strengthen exemptions. and 2 states had bills of both types. This is going through the states that had bills to strengthen exemptions are Washington, Vermont, Arizona, California, and Mississippi. This is looking at 2011 all the way through 2013, and 4 states during that time period enacted legislation to strengthen non-medical exemptions. Oregon just recently, Washington in 2011, Vermont in 2012, and California also in 2012. So I wanted to talk in a little bit more and focus about the state of Washington. They at one point had the highest number of, the highest percentage of exemptors, over 6%. And Dan showed the map of the Washington state counties, and some counties were up at 25%, really increasing the risk of disease to children. And Washington state also went through a pertussis outbreak during this time frame. So they enacted legislation in May of 2011. It requires a licensed healthcare provider to sign a certificate of exemption or to state in a signed letter verifying that the provider gave the parent or guardian information about the benefits and risks of immunization. So again, it's making sure that the parent has access to appropriate information from a healthcare provider. The form is not needed for parents who demonstrate membership in a church or religious group that does not allow a healthcare provider to provide medical treatment to a child, but they have to demonstrate that membership, and so it's not allowing them just to check a box. So since enactment of that law, exemption rates for children entering kindergarten in Washington state have dropped from over 6% in 2010 and 2011 to 4.6% in the 2012-2013 school year. 92.4% of kindergartners in 2012 and 2013 school year were vaccinated against pertussis, and this is the highest vaccination rate against pertussis for kindergartners since the Department of Health started tracking the rate in 2006 and 2007. Just to briefly touch on the other enacted legislation, California passed something similar to Washington state. Vermont had existing religious and personal belief exemption revised to require the use of a state-developed exemption form, and on which the parent and guardian to check off that they were given risk-benefit information, and it also requires annual renewal. Oregon just recently passed legislation that we're waiting for the governor to sign that removes the religious exemption. It basically puts all of religious and non-medical exemptions in one category, and it requires the parent and guardian to have either a healthcare provider signature that risk-benefit information has been given, or a certificate of completion of an internet provided vaccine module. So this is something really new, where the state of Oregon is going to be putting together an online education class that parents can take and get a certificate and present that certificate that they've completed this class and online in order for their child to be exempted from school law. Since Oregon has the highest rates right now, it's going to be really interesting to see the benefit of this new exemption law. So in conclusion, I just wanted to sum up by saying the school immunization requirements, they are an effective tool. The data that Dan went through thoroughly shows that. To assure high coverage rates to prevent vaccine-preventable disease in school children. We have found states using requirements that they are most successful when they're accompanied by public trust, by provider knowledge, and by public health support. And this really requires a strong, sustained investment in public health infrastructure. And we also recommend a robust implementation period for new vaccines. As we've seen, exemptions can be a challenge to states, and they can put children at risk. But now we're seeing exemption laws being strengthened over the past couple of years, and it's going to be very interesting to watch that. Dan mentioned putting together a model law for states, and We do know that, the politics are different in every state. It's difficult to get a law passed. It took Washington State several years to get theirs passed. But as the exemptions laws go into effect, we can see if they're working, if they're reducing exemptions, and if parents really are getting a better education and making wiser decisions about their vaccinations. I think that's it, although I wanted to acknowledge Diane Peterson from the Immunization Action Coalition is really an expert on state laws, and it's a great resource, this website. You can check state laws for every vaccine. You can check new requirements, administrative rules on the Immunization Action Coalition website. And the program managers, Greg Reed in Maryland, Jana Barty in Washington State, Lorraine Duncan in Oregon, Maria Volk in California. Also, Every Child by Two is a great resource, and Christine Vera has been doing a number of blogs on the trends in state requirement laws. Dan Salmon is the resident expert on childhood requirements, and Caitlin Wells from AIM was contributor to the cost and the economic impact. So thank you.
I'd like to thank both of our speakers. That was really a fascinating presentation. We're going to now take questions for both Daniel and Claire. People who are watching online, you can click on the link on your screen to send email questions for either or both of the speakers, or you can send your email directly to maphtc@jhsph.edu. That's a mouthful. For people in the audience, the live audience, if you could please wait until we bring you the microphone so that the people online listening can hear your questions. So let's start. Do we have any questions in the live audience?
Hi there. I'm wondering if requiring parents to do an online education, is there any evidence that that will actually change any minds, or is this more an administrative step that we think that they'll just have to jump through?
I'm not aware, Claire, you can jump in. I'm not aware of any evidence to show that it has an effect. In fact, if you look more broadly, not just for exemptions, but studies looking at whether vaccine education is effective in reducing vaccine hesitance, the literature and the science is really quite thin in that regard. And there are lots of information sources that are out there, but very few that have been rigorously evaluated. And the idea of doing this as a requirement for an exemption, while perhaps making sense intuitively, has not been evaluated to my knowledge. And I don't know, Claire, if you want to add to that.
Right, so I don't think there's any data about the online course. I think the goal is to eliminate the exemptions as a convenience, where we think that parents, there is a population of parents that is opposed to vaccination, but there is a population of parents that just needs additional information. And we saw the rates go down in Washington when they got media coverage about disease, and they required parents to talk with their healthcare provider. So nothing specific on the online tool. I'm sure that Dan will be studying that and give us some data on this shortly.
You know, a great anecdotal example of the need, and this was written up by a mother, and it's published in a supplement of Pediatrics, but this was a mother who had heard that vaccines were made from aborted fetal cells and didn't want to vaccinate because of it. She asked her pediatrician a couple of times and never got a clear answer, probably because the pediatrician didn't know. And she didn't get a straight answer to that question until her child was hospitalized for HIV and nearly died. And once she got a complete answer, and the answer is that some vaccines are manufactured from cells that originated in an aborted fetus. However, that it doesn't contribute to more abortions if one uses the vaccine. And in fact, high levels of the Catholic Church have come down and said that this doesn't cause a problem for Catholics. But one can only wonder if that parent had been given an answer to her question when she asked if perhaps her child would have been vaccinated and not contracted HIV.
Okay. I have a question online. Could you please comment on the value of health departments in enforcement of immunization regulations for schools and child care facilities? It seems that the importance has been diminished using lack of public health staff and funds as the rationale for reducing this monitoring.
I mean, as I talked about with the state of Maryland as an example, it's a tremendous public health effort to roll out a new requirement and to implement that. It's also a major commitment to enforce, and it's critical. And yes, there have been reduced resources to health agencies, but at the same time, it is a requirement to report to CDC exemption rates. Last year was the first time in the MMWR that they were able to publish the exemption rates because they've been collecting information, but it hasn't been sort of apples to apples across states. So they've been working on that. It's definitely a critical role for public health to monitor and track what's going on, and that's why I mentioned the importance of resources. Enforcing it does require partnership with the schools, and it does require significant investment in the public health.
Okay, for the live audience.
Hi. I have two questions. The first relates to a slide that Dr. Salmon presented. It was a matrix of the ease of exemptions and the rate of exemptions by state. And I was actually really surprised to see a handful of states, maybe 6 or 7, that had easy exemptions but also low rates of exemptions. And I saw some geographic variability, but I'm wondering if there's anything special about those states or other approaches rather than legislation or exemptions that led to those low rates. And my other question relates to HPV. And sometimes I think about seatbelt laws as being a similar kind of intervention compared to these school exemptions. And you wear seatbelts in cars in order to prevent injury. And I've heard the argument that school requirements for vaccines should relate to risk of disease transmission in schools. And so I'm wondering if that's come up in any of the discussions about HPV vaccines, since the disease can't be or wouldn't be transmitted in schools. And also if there's any discussion related to vaccines that target one gender or one subpopulation. And I know that's not such an issue for HPV anymore, but whether or not there are any challenges or issues with a vaccine that would would cause a greater burden for one gender or subpopulation than another for school entry.
So those are great questions. I guess I'll take a stab at them, and then Claire can add in or correct me if I get anything wrong. Your first question about states that have easy exemptions but low rates is an interesting one. And what we're looking at are associations between two factors, and there are many other things that may be related to those issues that one can't study in this way. So the argument is that states are your laboratory for these sorts of studies, and there's certainly insight that can be gained, as I think we've gained some in this regard. But there's lots of other factors, and I think the change in Washington exemption rates of recent time is a great example. So we've seen them come down. Now, is that because there was a change in the law, or is that because there was a ton of pertussis that was all over the media, and people therefore were more cognizant of the risks of disease? And looking at the rates can't answer that question, nor can I answer your question as to why those states had easy exemptions and low rates. But I suspect it probably has to do a lot with the attitudes and beliefs of people in that state. And it may be, in fact, that it may not be that the type of exemption or ease of exemption is causing high rates, but it may be, if one believes that the laws reflect the culture of the state, that maybe states that have a lot of people that don't want to vaccinate have laws that make it easy to not vaccinate, which is why a lot of people don't vaccinate. So the point I'm trying to get at is it's really hard to figure out causal relationships here, which is a long way of saying I don't really know the answer to your question. I think the second question you asked was about gender-specific vaccination? Or was that your third question? You did manage to get 3 in there.
But sorry, for HPV, also related to disease transmission risk in a school setting.
Yeah, it's an interesting argument. If you looked at when HPV was being introduced and debated for school entrance, this is one of the arguments that was common, which is that, one doesn't transmit HPV in a school setting, which I'm sure it has happened, but just hasn't been documented. But there are other diseases as well, like hepatitis B is not typically transmitted in a school setting, yet we often have requirements for it. And I think one needs to take a step back and say, or ask the question, why is it this requirement is being considered? For smallpox, it was to control disease. For measles, it was to control disease. And often schools were a site of disease transmission for measles. For some of these other vaccines, that's not the case. And I think you can make a reasonable argument that the strength of adding a school requirement is stronger when it's to prevent disease rather than other public health goals, although may be important, like increasing coverage, may not warrant as much weight as controlling disease, although they may still be important. The issue of gender-specific vaccination is an interesting one. If you look at rubella vaccine introduction, some countries, so with rubella, what you're most worried about is congenital rubella syndrome. You're worried that a woman who's pregnant, especially early in pregnancy, gets rubella, and it causes all sorts of problems for the children, including autism. So in fact, the rubella vaccine prevents autism because it prevents congenital rubella syndrome. Some countries like the UK try to target vaccination towards women of childbearing years. So the thinking was, well, if we make sure every woman who can get pregnant is vaccinated, we'll control congenital rubella syndrome. Other countries like the US went for universal non-gender specific vaccination. And I think the lesson from these two and many other countries is gender specific really didn't work. It would work hypothetically if you vaccinated every woman whom could be pregnant, but you won't. And as a result, disease will be transmitted, and you won't eliminate congenital rubella syndrome without vaccinating the whole population. A similar argument could be made for HPV. One is most worried about cervical cancer, although there's other diseases that can be caused by HPV, and that's obviously women that are getting cervical cancer and not men. Again, not that there's not benefit to the vaccine for men, particularly the Merck product that controls against warts, but initial attempts to vaccinate just women were inadequate. And if one wants to control the disease, we need to impact the population which often transmits the disease to women, which is the men. So I think if you look at these two examples, we see that gender-specific vaccination hasn't really worked terribly well. In terms of school laws, this could be an argument for why a vaccine might not be useful for a school law. Are you going to write a law that just applies to one gender? And presumably one could, but I think the epidemiology and history shows that one wouldn't want to target one gender anyway. Fred, do you want to add to any of that?
So I agree with everything Dan said, and I think that you've pointed out a really really big piece of moving forward around HPV vaccine. So we have lower rates, and maybe it doesn't fit into the original piece of preventing disease in schools, but it is effective to require vaccines in schools that will protect the community from vaccine. As far as targeting just females, the strength of school laws is one of the things we talked about with our statement is to keep the school law intact and to keep it one process and to not have a separate requirement for females or a separate requirement with exemptions over here and not to the original requirement, not to make those type of changes. So I think to keep the strength of the school law and the effectiveness, we would want to just add vaccines in their entirety. And HPV is now recommended for all all ages. And, maybe we're moving to a point where we really have to look at the HPV requirement again. Right now, there is not a requirement out there. That was one of the things that was discussed at the time. Is this a disease that is in schools, is transmitted in schools? So that is definitely, you've hit the nail on the head with the discussion piece there. On the philosophical exemptions, I think it is a lot of factors in the states and the culture, and it's also the culture of providers. Some states have more providers, they have more insurance plans. There's just different demographics around where people get the vaccine, and all of those cultural factors contribute to the population accepting the vaccine and not electing to take exemptions, I think.
I have another question online from a lawyer. Have you seen the articles by Mary Holland from the NYU School of Law? One is titled Reconsideration of Compulsory Childhood Vaccination, and the other was in a Yale Journal of Health Policy, Law, and Ethics in 2012, titled Compulsory Vaccination, the Constitution, and the Hepatitis B Mandate for Infants and Young Children. The National Health Freedom Coalition is citing these articles and other arguments to say that school laws are unconstitutional under due process and equal protection. And the questioner is asking for any comments or thoughts.
Yeah, so perhaps I almost gave a disclaimer when I started talking about the legal issues that I'm not an attorney, although we have worked with some superb public health law attorneys in this area. I'm not familiar with these articles, but I'll certainly look them up. I think the question that's being asked of whether or not states have the authority to require vaccination for school entry has been very clearly answered by the U.S. Supreme Court. But I wouldn't be surprised if there are lots of groups that have taken pieces of information and argued them to follow their own doctrine or arguments. I mean, there are a lot of groups out there that find this topic quite concerning. There's groups that have issue with vaccines. There's groups that have issue with the use of compulsory vaccination. And so, there's a lot of different players on different sides of the issue.
Okay, here's another question from online. Dr. Salmon spent some time discussing how unvaccinated children interacting with and going to school with vaccinated children pose a substantial risk to the latter. What exactly is the risk posed to vaccinated children by unvaccinated children, and particularly in areas where you showed clusters where there were a large percentage of unvaccinated children?
Yeah, this is a question that one often hears from people that want to forgo vaccination. And it goes something like this. If your vaccine works so well, what do you care whether or not my child gets vaccinated? Because your child will be protected. And if you admit that your child is at risk, then you're admitting the vaccine doesn't work well anyway, so why do you want me to get it? And it's somewhat circular in its logic. It's shown through lots of studies that no vaccine is 100% effective. And there's tremendous variability in the effectiveness. I mean, 2 doses of measles vaccine is probably 98 or 99% effective, which is really quite high. 5 doses of pertussis vaccine may not be more than 60% effective, and that can come down over time. There's some fairly convincing data for waning immunity. So it depends a lot on the vaccine. It also depends on the disease. I mean, measles is so easily transmitted that even a 1 or 2% failure rate, given that the disease is in much of the world, there's outbreaks ongoing in Europe. People are coming over all the time from Europe, and there's been most cases, there's no indigenous transmission or indigenous measles. It's been controlled effectively, but there are sporadic outbreaks that typically arise when someone goes from a part of the world like Europe, which there's lots of disease. They come to the U.S. Often it's in a community with high rates of refusal. There's an outbreak, first among the children that aren't vaccinated, and then as the disease is transmitting among children that are the vaccine failures, the 1 or 2% that didn't respond to the vaccine. But then public health responds, and as Claire pointed out, spends lots of time and money, and the outbreak burns out because there aren't enough susceptibles. And that's been the story until this point. So I think that answers the question. I mean, the risk is to children who aren't sufficiently protected from the vaccine, and that varies by vaccine, and also the characteristics of the disease and how easily it's transmitted.
Okay. Here is another question. Has there been any litigation or child welfare cases against parents whose children don't get vaccinated and do get sick?
Yeah, so you want to comment on this, Claire?
I don't know enough to comment on that. There was just legislation in Arizona around that. I think there have been some cases, but I don't know.
Yeah, I'm not aware of cases, but the American Academy of Pediatrics has a statement on this that came from their bioethical group. And so the question is for a pediatrician is if a parent refuses to vaccinate, should you report that parent to family services? And what their statement basically says is unless there's not a major outbreak of disease, the answer is no, that shouldn't be grounds for reporting a parent to social services.
Okay. Any other questions in the live audience? Okay. We have a couple more. Maybe we'll take one more question from online. What are the reasons that legislators are willing or want to have exemptions given the data that we've seen today?
You want to take that one?
Well, I'm not a legislator, so I won't put myself in their shoes. But, I think that legislators respond to constituents, and there are constituents out there who don't believe the science or are on a mission. They respond to things like that. There are legislators that act, in any number of ways. We saw that even in the U.S. Congress. Dan and I were talking about that earlier.
Yeah, I mean,
I don't know.
Surveys of the general public show that about 1 in 4 or 1 or 3 out of 3 parents are concerned about the number of vaccines given at once or in the first couple months of life. About a quarter of the public believes that vaccines can cause autism among otherwise healthy children, and about 7 out of 10 parents have some concerns about vaccines. And I wouldn't suggest that the average legislator is any better informed than the average parent in this regard. So I suspect that many of these misconceptions are held by legislators that are, as Claire suggests, influenced by their constituency.
Okay. Well, we've run out of time. We have a few more questions online, which maybe I'll forward to you. But I want to thank both Dr. Salmon and Ms. Hannan for a really stimulating grand rounds. And I hope everyone in the live audience and the online audience will remember to join us again August 21st, looking at the impact of policies on obesity prevention. Thank you.
Thank you.